Okay, awesome. Perfect. So yeah, let's start, and we will record this session so everyone who are not able to join or will join later, so that they can hear and see it. Welcome everyone to the webinar, Female and Male Infertility Workup. It's a pleasure to have everyone tonight. My name is Anastasia Timon. I'm a CEO and founder of Bloomy Leaf is a fertility marketplace that helps patients to find care, but we also a health technology company that enables monitoring at OBGYN office for fertility treatments. So if you offer right now blood draw and ultrasound or even prenatal care, you may be eligible for our monitoring pilot. But let me introduce you to our amazing guest. Dr. Joshua Klein, it's a pleasure to have you today. Dr. Klein is a board-certified reproductive endocrinologist. He is a medical advisor at Bloomy, but he is also a co-founder and chief clinical officer at Extend Fertility, and also an assistant professor of OBGYN and reproductive science at Icahn School of Medicine. Dr. Klein published multiple papers at peer-reviewed academic journals such as Fertility and Sterility and Obstetrics and Gynecology, and also presented his research at national conferences such as ASRM. It's a pleasure to have you today. Thank you so much for joining us. Before we start, so a few housekeeping items before we're pulling out our slides. So the webinar is 45 minutes. And we would have 15 minutes of Q&A session at the end. So if you have your question, there is a Q&A button at the bottom right of your screen. So if you can see the 3 geometrical figures called activities, within that there is a Q&A section. So you can leave your question there, and we would make sure to answer all the questions at the end of the session. But I will hand it over to Dr. Klein to start telling us more about the fertility workup.
Great. Thank you so much for joining tonight. And thanks, Anastasia, for asking me to present. So I am a reproductive endocrinologist. So I spend my days and nights worrying about fertility and IVF and freezing eggs and all that kind of stuff. But the focus for tonight is going to be to try to break down in a very straightforward way from the generalist perspective, the general OBGYN's perspective, what would be a methodical way to kickstart a fertility evaluation and a fertility workup. I know that when I was finishing my OBGYN residency, it was all a blur. And maybe that was just me, but it certainly, my residency did not prepare me, I'd say, to tackle fertility confidently. Lots of OBGYNs, I think, over the years developed their interests and their skills in that direction, but it can be daunting. And so I think it's helpful to think of it in a conceptual way that can keep the sort of methodical approach to how to get the ball rolling for a patient or a couple who is trying to get pregnant and isn't having an easy time of it necessarily. So without further ado, we'll aim for this to be about 45 minutes. And what I want to try to cover sort of quickly and briefly is, number one, we'll spend a few minutes talking about what the definition of normal fertility should be. How long is too long, in the sense of at what point do we think that it does make sense for a patient or for a couple to pursue fertility evaluation. And just generally,
Dr. Klein, yes. I'm so sorry. So I think we cannot see your screen. There is some technical problem. So can you check again so you see it? We just, don't see it before you switch to a new slide.
Hang on a sec. What do you see now?
Oh, yeah. Perfect. Great. Yeah. So just when you, I think, start the slideshow, then you will see. Okay.
So should I keep it off the slideshow then?
Can you put the slideshow on again, and I will tell you if it's not working. Okay. Oh no, for some reason it's not working. Okay, so let's just keep it without the slideshow.
Okay,
awesome. Yeah, so we can see.
I can try
Sorry,
to max.
everyone. Yeah, we apologize for technical difficulties tonight, but
Got it. I'm going to try to maximize here. If that's helpful. Oh, I guess I'll just leave it like this. I think it's probably
it's
good enough.
It's good.
Okay.
It's good. Thank you, and sorry about that.
No problem. Okay. Again, the idea would be to try to kind of break down trying to define some degree of a line between normal fertility and then infertility, and using the basic concepts of how normal fertility generally works, and then delving deeper into when we think that there may be a problem, how to approach the big topic of fertility problems, which of course can involve multiple different biological systems, and how to kind of break that down in a methodical way to help bring some clarity to the situation of what might be the issue that deserves most attention. So with that being said, first of all, this is a figure from a relatively old paper, but I think that the key points that I want to emphasize in this slide are, number one, that for normal, healthy people who are in their 20s trying to conceive, the monthly chance of conception starts somewhere between 20 and 30%. That's pretty consistent across most studies. And so there is some degree of variability in the sense that even the most fertile couple, of course, is not going to conceive, or is not expected to conceive every single month that they try. But the other idea that this slide is illustrating is that the longer a couple is trying naturally and not succeeding, the lower the statistical chance of pregnancy becomes. And that's really, of course, a statistical function, which is to say that the couple themselves do not change their biology by being unsuccessful for longer, but rather because in a normal setting, if you're getting a 20 to 30% chance per month, most couples who are fully fertile will be pregnant within 3 to 6 months. That means that couples who've been trying for 6 or 9 or 12 months, their monthly chance of conception is going to be dipping under 10% and even under 5% per month. And so it's a fair, I think, approach to basically say that for most couples, certainly younger couples, to not be concerned about fertility within the first 3 to 6 months. But then if a couple has been trying for more than 6 months, it's already of interest. And certainly more than 12 months is going to be something that really deserves attention. There's another dimension here, which we address on the next slide, which is age. It's more important for an evaluation to begin for particularly age of the female, because the biology is different on the female and the male sides, for there to be an evaluation sooner for a woman who is in her late 30s or certainly in her 40s. Basically, the chance that there's going to be a requirement for some kind of intervention is certainly much higher for women in their late 30s or 40s. And we don't have as much luxury of time for someone who is older. And so the typical recommendation is that an evaluation should begin no later than after 6 months of trying for women who are older than 35 years old. So that's just some background information that's probably pretty familiar to most OBGYNs, but just reviewing that. Now, this is data from a study that was published in 2016, and it's one of the best contemporary studies on natural fertility and how it relates to age. And so basically, these were almost 500 women who were followed prospectively for up to 12 months with no previous infertility diagnosis, no previous infertility history. And they essentially just recorded the incidence of pregnancy, and the data here is, of course, stratified by the age categories. And so what you see is that for women in their young 30s, on the left-hand part of the figure here, the chance of pregnancy per month was just shy of 20%. But for women in their late 30s or 40s, the chance of pregnancy per month was 5% or less. And then if you sort of translate that into a cumulative pregnancy rate over the course of 6 or 12 months, you can see again that younger patients, about 75% of the patients were pregnant within 6 months of trying, and about 85% of patients were pregnant within a year. Whereas for older patients, 38, 39 or older, the chance of pregnancy within 6 months was only about 1/3, and the chance of pregnancy within a year was just lower than that. And so it's very common that for women in their late 30s or 40s, there's going to be a long road to pregnancy if it's going to occur. And so again, it becomes more of a priority to be a little bit more proactive about doing a diagnostic evaluation, at the very least, to rule out any specific and addressable issues, as we're going to talk about, whether that means blocked fallopian tubes or sperm issues or hormonal issues that can be addressed medically, as we're going to try to break down in the next few minutes. Okay, so this is a slide that I use sometimes for patient-facing presentations, and so sorry if it's too elementary, but of course the basic idea is that the hormonal cycle, the expected monthly development and ovulation of an oocyte, of an egg, is controlled most directly by the pituitary gland and FSH and LH, which are products of the pituitary gland. And of course, the pituitary is controlled by the hypothalamus. But that feedback loop of the FSH and LH coming from the pituitary, communicating with the ovary, and then the ovary producing the gonadal hormones, estrogen and progesterone, is really the core of what we look at when a reproductive endocrinologist is trying to unpack what the hormonal status of the patient really is. This slide may be familiar to many. It's basically trying to, of course, organize the different phases of the menstrual cycle from the various different angles. So on the top line, or I should say, just to orient you, this is a 28-day cycle presented horizontally. In the center of the figure is day 14, which is sort of the idealized day of ovulation. And so the top line here, you have a representation of what's going on in the ovary. You have a recruited follicle that becomes an antral follicle that becomes ultimately a dominant follicle, leading to ovulation, the release of the egg, and then the formation of the corpus luteum during the post-ovulation, the luteal phase, and then ultimately the degeneration of the corpus luteum as the cycle comes to an end, if it is not salvaged by the presence of HCG, meaning by the presence of a pregnancy. The next line here is just showing the way that basal body temperature reflects the phases of the menstrual cycle. As you can see, the variations in body temperature and basal body temperature are very slight. They generally run between 36 and 37 degrees Celsius, so less than 1 degree Celsius, and they can be pretty variable. So a lot of patients are often encouraged early in the fertility journey to track their cycles using basal body temperature. I'm not the biggest fan of that type of tracking because I think it can be very confusing and sometimes frustrating for patients, because it even with a specialized thermometer that's designed for this use, it can be less than clear to demonstrate the pattern of temperature rise in the luteal phase. The next line is sort of what the OBGYNs may sort of have some PTSD from their boards exams. The hormonal dance that controls the menstrual cycle from a serum hormone perspective. The key piece is basically being that in the follicular phase, the growing follicle secretes estradiol, estrogen. And so the estradiol level starts low and it increases as you approach ovulation. At the time of ovulation, it often dips and then stabilizes. So that represents the typical pattern of estradiol levels. Progesterone is, of course, the key hormone of ovulation. You may or may not know that the name progesterone, it was coined progesterone in the 1920s. Pro as in supporting, gest as in gestation, and erone as in the hormone. It's the hormone that supports gestation. So it's the key hormone to support pregnancy. Levels of progesterone usually are approximately 1.0 or less in the follicular phase and should rise to at least about 10 or 15 in the mid-luteal phase. If there is no pregnancy, then they dip at the end. One thing I do want to point out about progesterone levels is that they do not shoot up at ovulation immediately and stay high from day 14 all the way till day 27 and a half and then drop abruptly, but rather they rise gradually and then they have a plateau, and then they decline somewhat gradually at the end of the cycle as well. And so if you check a serum progesterone, if it's above approximately 2, you can be confident that you are catching a luteal phase. Progesterone should not be more than about 1.5 or 2 unless an ovulation has occurred. But the idea of progesterone sufficiency or deficiency is tricky, because depending on where you're catching that progesterone level during the cycle, if you check a progesterone level on day 15 or 16 or 17 or the equivalent, meaning within a few days after ovulation, you may catch a low level, but that doesn't necessarily indicate a problem because the progesterone is on its way up. Or in a similar vein, if you catch progesterone in the last few days of the cycle, you may see a low level, but again, it may just be on the way down at the resolution of the cycle. And so it's important to keep in mind this pattern of progesterone rise and decline through the course of the cycle. And then the red and the green, of course, are FSH and LH. FSH and LH being the hormones that are primarily responsible for the recruitment and growth of the ovulatory follicle. Of course, you have your LH surge just before ovulation, approximately 24 to 36 hours before, which triggers ovulation. And then those hormones tend to return to low levels in the luteal phase. And finally, in the last, from the last perspective, you have the level of the uterus, where this figure is demonstrating menstruation and the shedding of the lining in the first few days of the cycle, and then a gradual buildup of the lining, a proliferation of the lining as influenced by the increasing levels of estradiol. That's what estradiol does. It induces cellular proliferation to thicken the lining. This figure is imperfect because the lining typically achieves maximal thickness around the time of ovulation, and it doesn't continue to necessarily get much larger in the luteal phase. So you'll have to pardon the imperfection. But in the luteal phase, you have cellular changes that are induced by the presence of progesterone that cause the lining to become receptive. And so the sort of elegance of the system, and one of the reasons why I'm attracted to reproductive endocrinology to begin with, is because you have this delicate dance of intersecting organs and organ systems that are all contributing to the same process. You have the development of the egg and the activity of the granulosa cells that are producing the estradiol, and the estradiol is thickening the uterus to prepare for the oncoming ovulation. And then ovulation will then facilitate the production of progesterone from the corpus luteum, which then facilitates implantation of a potential embryo in the lining. And then, of course, as I mentioned earlier, that corpus luteum will degenerate unless a pregnancy occurs. If a pregnancy occurs, it will implant and it will begin to produce HCG, which then feeds back to the corpus luteum and essentially rescues the corpus luteum. And you have this beautiful interaction between the corpus luteum and the conceptus and the early pregnancy, where HCG salvages or rescues the corpus luteum, and then the corpus luteum is rescuing the pregnancy by producing progesterone, which is necessary for the sustenance of the pregnancy. Okay, I'll rein in my my passion there, but that, I think, is in one figure. You can get so much of that interaction of the different systems that really are all required to do a delicate dance to work together and facilitate pregnancy. Okay, so now in a much more concrete way, of course, and again, this is for OBGYNs probably besides the point here, but you're all familiar with the pelvic anatomy, and I imagine that you would all be familiar with the idea that normal fertilization will occur in the distal segment of the fallopian tube. Oocytes do not move much. They're ovulated, they're received by the fallopian tube, and then they wait for sperm to make their journey up into the distal end of the fallopian tube. So fertilization occurs here. For the first approximately 3 to 4 days of cellular division of the early cleaving embryo, that all happens in the fallopian tube, and the embryo typically arrives in the uterine cavity somewhere between days 5 and 7 of conception, and implantation will occur between days 7 and 10. And so the first 7 to 10 days of existence of the fertilized egg are sort of involve this travel, which is why, of course, pregnancy, HCG, cannot be detected in peripheral blood until approximately 12 to 14 days, certainly no less than about 11 or 12 days post-ovulation, because implantation, attachment of the embryo to the uterine lining is only first occurring days 8, 9, or 10. And so you're not going to be able to perceive the presence of any HCG until a couple of days after that. Okay, so now let's move on to talk a little bit more about how to approach a patient or a couple who's having a difficult time conceiving. And so, this is the, I think, most simple way to break down conceptually the potential causes of infertility. You have egg issues, you have sperm issues, and you have anatomic issues, or what I usually refer to as the plumbing. And all known causes of infertility to some degree will belong relatively neatly in one of those boxes. So let's spend the next few minutes trying to delineate that in more detail. So one version of egg issues is ovulatory dysfunction, meaning women who have eggs and healthy eggs, but the hormonal dance that we looked at earlier that is responsible for inducing the regular growth and ovulation of those eggs is not functioning properly. So ovulatory dysfunction as a term includes any type of hormonal imbalance that can affect the signals that are coming from the pituitary to the gonad to the ovary to get the eggs to grow. By far the most common version of significant ovulatory dysfunction that we see day to day is polycystic ovary syndrome, PCOS. It's common enough that we'll spend a couple of minutes on PCOS specifically. PCOS, of course, is characterized by irregular menstrual cycles, which are really a reflection of the lack of regular ovulation, in addition to characteristic appearance on ultrasound, in addition to the presence of elevated levels of androgens relative to female-like hormones. And we'll get into that in a couple minutes in a little bit more detail. Of course, there are some non-ovarian hormones that can interfere with proper ovulatory function. And so some of the common ones, of course, can be thyroid issues, prolactin issues, or general medical issues such as significant metabolic disorders like diabetes. And then you have the whole category of hypothalamic sources of hormone balance issues, which include pretty much any situation that's going to affect the function of the hypothalamus and the GnRH secretion. GnRH is, of course, the messenger that communicates with the pituitary, and anything, including medical illnesses, but also any stressor, physical, emotional, psychological, and so forth, can and will affect the secretion of GnRH and ultimately of FSH and LH. And so, simply put, the body knows that when there is a situation of distress, whether that's physical, psychological, or otherwise, it may not be the best time to be devoting resources to reproduction. And so it's sort of an evolutionary tool that has been in place to kind of shut down the function of the female reproductive system in times of stress. Usually, in cases where there is a significant hypothalamic component to ovulatory dysfunction, you will see FSH and LH levels being pretty low. Now, in the obvious cases, FSH and LH levels, which typically you'll see somewhere in the mid to upper single digits, 4, 6, 8, something like that, for both of those hormones. In cases of hypothalamic dysfunction, you'll often see those levels being less than 1, sometimes as low as 0.01. Sometimes it's less clear. If you have an FSH and LH of 2 or 3 or 4, that's certainly lower than typical, but not always so explicitly obvious that we're dealing with a hypothalamic dysfunction situation. Okay, we'll go to the next slide, which is focused on PCOS. This graphic is trying to represent the idea that according to most of the medical societies that issue guidance on PCOS, the diagnostic criteria for PCOS are going to be 2 out of 3 of the big 3, which is to say ovulation problems leading to irregular cycles and potentially infertility, hyperandrogenism as reflected either in blood testing or in symptoms like acne and hirsutism, the third criteria being the abnormal appearance of the ovaries, meaning polycystic appearing ovaries on ultrasound, which I suspect that most of the audience are familiar with. And the reason that ovaries appear polycystic is essentially you have the activation of dormant follicles continues during polycystic ovary syndrome, but you do not have the regular cycling of those follicles to grow into mature follicles and leading to ovulation and corpus luteum. So essentially, it's almost like I tell patients you have a traffic jam. You have follicles waking up and becoming activated and waiting their turn in the rotation to become a follicle that leads to ovulation, but the process kind of has a log jam where it doesn't get the right input for the cycle to progress. And so you get an accumulation of an overabundance of these baby follicles, of these immature follicles. And that leads, of course, to the characteristic appearance on ultrasound. There's definitely the reality that the abundance of follicles is typically located around the periphery, that sort of pearl necklace appearance that is probably somewhere in the board's materials is definitely something that we do see very regularly. And the other thing to say, but without getting too far afield here, is that the local environment in the ovary then becomes a self-fulfilling problem, which is to say when you have an overabundance of these immature follicles, it does lead to a derangement of the local concentrations of LH and FSH, which only further exacerbates the inability to progress to ovulation. So much so that this is an approach that really isn't common these days anymore. But if you look in the literature, an approach to resolving or at least relieving ovulatory dysfunction in the setting of PCOS historically was to traumatize the ovary, or what people called ovarian drilling, to relieve some of that crowdedness of the ovary, which actually did have real measurable benefit. People would become ovulatory for 6 to 12 months at a high level after ovarian drilling surgically. It's not a treatment that's common anymore because it's too traumatic and probably not one that would be pretty acceptable to most people. But in theory, that is something that can be used as a tool to help relieve the ovulatory dysfunction. Okay. So what causes PCOS? Patients always ask that, and the answer is it's hard to really put our finger on it. We do know that there is some degree of genetic influence, of course, and we also know that there is a significant degree of environmental influence in terms of the relationship between PCOS and metabolic disruption, specifically insulin resistance and glucose intolerance and being overweight. And so, again, this is our session tonight is more about diagnostics, but at a very basic level, I'm sure all of you have either seen patients who specifically focus on diet and exercise. And if a patient loses at least about 5 to 10% of their body weight, a significant proportion of them will have a noticeable improvement in their menstrual regularity. Again, I don't want to get too far afield into the nuances of PCOS, but there's definitely that sort of foundational idea that it's an interaction of genetics with some environmental triggers. Okay, so that segment for the last few minutes was about egg issues where we have the eggs, but they're not functional, meaning that the hormones are not allowing them to be ovulated and released on a regular basis. A more foundational issue is, do you have the eggs altogether? And so one of the things to consider, particularly in older patients, meaning in patients in their late 30s or 40s, but not exclusively in older patients, because I think it's important to be aware that there are many women who are in their 20s or early 30s that actually already show signs of diminished ovarian reserve or low egg supply. It's a natural process that every woman starts out with a large volume of oocytes of eggs. And those eggs are constantly undergoing apoptosis, meaning there's a continual diminishment of the ovarian reserve until eventually it is normal for a woman to have no eggs remaining. But there is a very large degree of variability in ovarian reserve and egg supply, even for a given age. And so, for example, in this figure, which was published by Seifer et al. About 10, maybe even 12 years ago, you can see that as reflected in AMH you're probably familiar with as anti-Müllerian hormone. We use that a lot in the fertility world, of course, and we use it primarily as a marker, a simple marker for ovarian reserve. But you can see the mean, the median, and the standard deviation here, and it's a very, very significant standard deviation, meaning for a given age, there is a tremendous amount of variability. A woman who's in the 90th percentile for age 40 is going to have an AMH of about 2 to 2.5, which is similar to the median woman who is 30 years old. So if you're a lucky 40-year-old, you may have as many eggs as an average 30-year-old. And vice versa. If you're in the 10th percentile at age 30, your AMH will be 0.5 or less, which is a median value for a woman in her 40s. And AMH has become really, really, I think, useful because it really is quite stable. It can be drawn any point in the menstrual cycle with a reliable degree of accuracy, and it's easily accessible. It's not particularly expensive. Most insurances will cover AMH testing. And so it's fast in the last 5 or 10 years become the sort of go-to data point when we want to get a sense of ovarian reserve. Bottom line is that in a younger patient, it's something that I think is pretty much always worth looking at least for reassurance, if nothing else. In an older patient, it can help us, I think, it can help provide a degree of urgency to the fertility journey. A patient who's in her late 30s or 40s with a very low AMH is already kind of in a certain way facing a much steeper road ahead than a woman who has a very good AMH. And so age matters a lot, and it actually matters more than anything else when it comes to fertility, female age. But the reassurance of a young age is sometimes mitigated by a low AMH for age. And the urgency at an older age can be sometimes mitigated for someone who has a above average AMH for their age. On this slide, of course, we have day 3 FSH, which historically was before AMH became so popular, sort of the way to get a sense of ovarian reserve in a monthly cycle basis. AMH is better because it's more stable. We still do look at day 3 FSH or day 2 FSH to have a sense of what's happening in the dynamics of that particular cycle, but we don't rely on it as an overall measure of ovarian reserve because it's going to vary so significantly from one month to the next. And then antral follicle count, of course, is an ultrasound assessment of how many visible antral follicles there are early in the menstrual cycle. Despite our emphasis on trying to standardize antral follicle counts, even within the fertility clinic world, it's very difficult to have a standardized approach to which little follicles should count or should be counted. And so we certainly, again, lean on AMH as a much more stable marker of ovarian reserve, but we do look at antral follicle counts as well. And in conjunction with, within the topic of egg issues that relate to the availability of healthy eggs, so what we were just talking about is egg quantity, which is the amount of eggs remaining. The parallel issue is egg quality, which is to say that amongst the eggs that a woman has, some of them are euploid, which is to say they have the correct genetic complement, the correct amount of chromosomes, and some of them are aneuploid. And the way that egg quality changes as a woman goes from her 20s to her 30s to her 40s is that the percentage of euploid to aneuploid eggs is shifting. Women in their 20s have something like 90% normal eggs and only about 10% abnormal eggs. Women in their 40s, it becomes the mirror image opposite. By the age of 45, about 90% of the eggs are aneuploid and only 10% are going to be euploid. And of course, in the 30s, it's in between. And so for better or worse, the reality is that we do not have any good tests or any real tests at all of egg quality. But at the same time, we can live without testing egg quality because we know that age is a very, very reliable indicator of egg quality. So much so that there really aren't exceptions to the rule, meaning women in their 20s will always have a high proportion of healthy eggs, even if they're not generally very healthy people. But the opposite is also true as well. Women in their 40s will always have a high proportion of unhealthy eggs, even if they're very healthy people. And the experience in the IVF lab over the course of the last 40 plus years has really borne that out. It is a very reliable and predictable pattern that the age of the eggs will almost always correlate strongly with the health of the eggs that are available to be fertilized for use in the laboratory. This figure here is basically the closest approximation to a direct measure of the percentage of normal to abnormal eggs that we see. You cannot test the genetics of an egg without destroying the egg, but what you can do is you can test embryos. If we fertilize eggs in the laboratory and allow them to grow, we can do a biopsy and remove a few cells to get some of the DNA from that embryo, and of course do a genetic analysis on that biopsy sample. And so you can see clearly that women in their 20s will have a significant but small proportion of their embryos, or embryos that come from their eggs, will be aneuploid, meaning abnormal, somewhere between 20 and 40% up to about age 30. The very young patients actually seem to have a higher proportion of aneuploidy that no one really understands the mechanism of that under age 25. But the lowest incidence of aneuploidy is about 25 to 30, which is at the ages of 25 to 30, which is about 20 to 30% of embryos will be aneuploid. And then as a woman progresses through her 30s and into her 40s, this incidence of aneuploidy, of course, increases very substantially. Above age 40, we're talking about 60, 70% aneuploid. As you approach age 45, you approach about 90% of the embryos that are created are going to be aneuploid. And so this just really reflects that fundamental challenge for patients as they get older of finding healthy eggs to work with. And I emphasize this to patients. We don't need to spend too much time on it. This is an old figure from the CDC on IVF success rates, but the basic idea is that even IVF is not a great strategy for helping women conceive if they're in their 40s, because IVF, of course, relies on the availability of healthy eggs. And most women in their 40s have two problems. They have a lower egg supply, which means that when we do IVF, they don't make as many eggs to work with. And of the eggs that we are able to retrieve, the majority of them are not healthy. And so IVF is a very powerful tool for women in their late 20s or early 30s up to sort of the mid 30s, but it really becomes an increasingly poor tool. It may be the best we've got, but it doesn't work very well for women who are in their 40s. Okay, so thus far, we've got some smiley face icons here, I think, that are a little bit off kilter, but we've covered egg issues. And again, to summarize, there's the functional egg issues for ovulatory dysfunction like PCOS. And then there's the presence of egg issues, which is both egg quantity and egg quality, as we've just been discussing. So now let's move on to the next smaller topic, which is anatomic issues. We've already spent a little bit of time looking at this slide covering the normal anatomy. And of course, as we said, the fallopian tube is the location for fertilization. And the fallopian tubes, as you all know, are small and delicate and can often be injured or damaged in the presence of lots of different processes, including infection, like PID, inflammation, like endometriosis and chronic inflammation, or any type of surgery, whether that be something in the neighborhood like an appendicitis or appendectomy, or something even closer to home like an ovarian cystectomy or C-section. And so anyone who has some history of surgery, infection, inflammation is going to be someone that we look at and think about very carefully with regard to the health of their tubes. These are some images from a hysterosalpingogram. These are pretty old images, but they get the point across. You can see the wisps of X-ray dye that are traveling through the tubes in the right and the left in this image. And here you have hydrosalpinges, a collection of the X-ray fluid that is collecting at the distal end of the tubes on both sides in an abnormal HSG. Of course, you can evaluate tubes intraoperatively if you're doing a laparoscopy with an infusion of dye. And of course, these are just some images to demonstrate that idea. Okay, so in sort of creating this punch list, we've talked about egg issues, we talked briefly about anatomic issues, and then let's talk just for a moment about sperm issues, because we can't forget that the male is a big piece of the puzzle here. So one thing which I think is starting to kind of come through more and more these days, but is that male factor is a very common cause of infertility. Depending on which study you look at, it is the primary cause of infertility in up to 30% of infertile couples. It is at least a partially causative factor in at least another 20%, which is to say that there is the presence of male factor, at least to some degree, in about half of couples who are struggling with fertility issues. Of course, there are different categories of male factor infertility in the sense that there are different reasons why a man may not be ejaculating an appropriate number of healthy sperm. And without getting too far afield into the urology, you can think about them categorically in the sense of hormonal reasons, some deficiencies in the HPO axis in the male, genetic issues that lead to a failure of sperm production, anatomic issues that can lead to obstructive low levels or absent sperm, and then of course idiopathic, which is quite common. This next slide is about recurrent pregnancy loss, which we'll cover in a second. But what I basically would summarize is that a semen analysis, which of course is an evaluation of the semen under the microscope, still is the main tool that we use to diagnose male factor infertility. If someone has questions about specific parameters, I can go through it in more detail, but the most important parameters on the semen analysis typically are volume, concentration, which is the number of millions of sperm per milliliter, percent motility, which is the percent of motile and moving sperm, and percent morphology, which is the percent of sperm that are a perfectly normal shape. There are lots of sort of fancier, newer tests like DNA fragmentation index that some people find more or less valuable, but the sort of textbook approach, which is supported by evidence, is generally that a semen analysis is quite valuable and can be strongly predictive. More of the nuanced, fancier, newer tests are all sort of in the bucket of controversial and maybe helpful in individual cases, but not for routine use in the diagnosis or evaluation of male factor infertility. So it bottom line boils down to the idea that a semen analysis is the go-to to evaluate for male factor. We included a slide about recurrent pregnancy loss because it is such a common situation, unfortunately. As an REI, we do think of infertility as a somewhat separate subject from recurrent pregnancy loss, mainly because most of the biology is different. People who are getting pregnant and losing pregnancies, the recognizable etiologies of those pregnancy losses are generally not the same as ones that cause infertility. Typically, once again, there's a lot of esoteric and sort of newer testing that people advocate for recurrent pregnancy loss. Personally, I try to adhere to the testing panel recommended by the American Society for Reproductive Medicine, which is relatively straightforward. It includes, this is often missed, but a karyotype for both the mother and the father, right? So we're looking for a balanced translocation that can lead to an abundance of sperm or eggs, of gametes that have an unbalanced complement of DNA. And that is an etiology that can equally come from either the male or the female partner. That's the one test that we routinely need to remember to do for the male when it comes to recurrent pregnancy loss. The rest of the testing, of course, is within the on the female side, which is to assess the uterine anatomy for normalcy, looking for things like a partial septum or other congenital Mullerian anomalies, abnormalities in the shape of the uterus. There are different imaging modalities you can use to look at the uterus, looking for hormonal issues like thyroid and prolactin. Of course, if you have genetic material from a previous pregnancy loss, that can be very helpful in terms of understanding the pregnancy loss. And then looking for thrombophilias related to lupus anticoagulant, anticardiolipin antibodies. We test the anti-beta-2 glycoprotein. And then finally, general illnesses like metabolic conditions like uncontrolled diabetes will certainly raise the risk for miscarriage. And it's definitely worthwhile to look for those things. I can't tell you how many times we have diagnosed general medical illnesses in the setting of recurrent pregnancy loss evaluations. Okay, so as a summary and sort of trying to round third base here heading into home. So if you have a patient or a couple in front of you and you're thinking about what would be a thorough basic approach to fertility testing, what I would recommend is for any woman, a pelvic sonogram to screen for obvious anatomical issues, major fibroids we didn't really talk much about, or ovarian cysts, or hydrosalpinges, those type of anatomical issues that can be found on the spot with a transvaginal sonogram. Also, you can look at the ovaries and look for an antral follicle count if you're comfortable doing that. For blood work, it's not as vast as I think most people imagine. The basic blood work that I would recommend doing for any woman where we're looking at fertility would be TSH, prolactin, AMH, a basic infectious disease panel, and looking for rubella and varicella immunity. I routinely offer expanded genetic screening like Natera or Semaphore, although Semaphore is out of business now. But basically looking for monogenic diseases, I think it's sort of has become in the modern era our obligation to give patients that option. We do let patients decline genetic screening if they're not motivated to do so, but we do try to make sure that we routinely offer all patients expanded genetic screening. And then to look for male factor, a basic semen analysis. These days, there are even companies that will offer an at-home semen analysis where a man produces a sample at home, and then they give you this little kit where you package up the sample and send it in through FedEx, which I know sounds a little crazy, but there's multiple companies that offer that. So for men who are reluctant to make the appointment and show up and produce a sample in some room that they don't feel comfortable with, that's not really a good excuse anymore. And then a hysterosalpingogram for anyone. I do offer it, or I should say suggest it for patients even without risk factors, because it's just such a basic element of our understanding of the ingredients. So with this short list here, you're covering basically all of the subjects we've spoken about so far: egg issues, both the quantity of eggs, the quality of eggs is reflected in age, and also the functional status in terms of hormones, and then a semen analysis and an HSG to cover male issues and anatomical issues. I do routinely add, for those with obvious cycle abnormalities, additional testing looking at androgens, and specifically to look for PCOS with free and total testosterone. 17-hydroxyprogesterone is the one that would be elevated in the condition congenital adrenal hyperplasia, CAH, which I'm not going to cover in tonight's discussion because it's a little out there, but it's worth differentiating between sort of run-of-the-mill PCOS and CAH by looking at a 17-hydroxyprogesterone. DHEAS is a screening test for an adrenal source of androgens. That's rare, but if everything else seems normal, but there's a sky-high DHEAS, you may need to look at adrenal imaging if you're not referring that to an RE. And then a hemoglobin A1C and a lipid panel, just because those things are so frequently elevated or abnormal in PCOS patients. Of course, the hemoglobin A1C can be helpful to identify patients who may benefit from diet, nutritional, exercise type of interventions, as well as metformin. Okay, so just to sort of try to summarize, if we have a patient Jessica, who's a 30-year-old who's never been pregnant before and has been trying for the last year. She has irregular cycles that come every 1 to 3 months. What would be appropriate testing? Well, number one, I would say that for a 30-year-old who's been trying for just a year, yes, I would pursue an infertility evaluation because it is not normal. But the obvious thing, of course, is that if she's not cycling regularly, she's not getting regular opportunities to conceive. And so doing the full blood panel testing, including the androgens that we were just talking about to identify PCOS, is definitely something that I would consider. I would offer an HSG. I certainly wouldn't force this patient without risk factors, if there are none, to do an HSG. I try to routinely push for semen analysis, even if the guy isn't so excited about it, just because it is so common for there to be a male factor contributing. And this is a patient, I think, that certainly, given her young age and her less than daunting history, is one that an OBGYN who wants to start the evaluation, it would be very much appropriate to at least begin the evaluation with the OBGYN in this setting. Whereas, Denise, that is a Denise, I think, is a 42-year-old who has had a history of an ectopic pregnancy in the past, a history of miscarriage. She's been trying for 2 years. For this patient, I definitely would be more aggressive about recommending completion of the full panel, other than if she has regular cycles. We don't need to worry about the androgens. We don't need to worry about 17-hydroxyprogesterone, but I would be very interested in seeing her AMH to get a sense of, is she lucky, unlucky, or somewhere in the middle with regard to her egg supply, given her age. And I would definitely look at the sperm, because there's not much time to waste to identify a sperm factor, male factor, if it's present. I would definitely want an HSG, especially with this history of an ectopic pregnancy in the past. And this is a patient that I think it's totally reasonable to start the evaluation, but to have a low threshold to refer out, because this is a patient who does not have a lot of time to waste. And moving on to trying whether it's IUI or IVF, which presumably being done in the setting of a reproductive endocrinologist, is something that probably should be done relatively sooner rather than later. Okay, I think that covers the core stuff, and I hope it wasn't too quick or too slow. But I'm going to hand over the microphone, I think, to Anastasia.
Yes, thank you so much. I feel like I learned a lot about fertility evaluation as a patient myself. So that was a very deep dive. And of course, it was very educational, very interesting to learn about all these factors. And as you can see, a lot of you can start doing basic tests that Dr. Klein mentioned in your practice already today. So I want to spend a few more minutes of this webinar telling you about the way you can grow your practice today by joining our network. So if you are, I'm sorry. So if you are already offering blood draw and ultrasound or fertility assessment, even if you're doing prenatal and postpartum care, as I mentioned, so you can let your patients know about the services that you offer and get listed for free at our platform. So this is how our platform looks like. So the patients who are in the location close to you would be able to see you right away and see all the services that you offer. So I would definitely use that opportunity. I'm going to share with you the link to join our network and get listed here in the chat. But we will also share it after the webinar.
Oh, sorry.
Yeah.
Sorry about that.
Oh, good. So in addition to that, you are able to grow with our partnerships. We have partnerships with fertility centers and surrogacy agencies all across the United States, and you can offer monitoring for their patients for fertility treatments and surrogacy treatments. So if you're interested in learning more about this partnership, please reach out to me after this webinar. And otherwise, that was pretty much it. I don't think we have too much time to cover the questions right now, but we would definitely share with you the recording of this webinar and the cheat sheet that Dr. Klein provided on all the testing that you should be doing already in your practice. Thank you so much again for joining us tonight and for your knowledge and sharing that all with us. Thank you so much.
Thank you.
Thank you, everyone. Have a good night.
Good night.